So Bryan, please.
Thanks, Chris. Good morning, everybody. Thank you very, very much for having me. I feel a little weird tethered to this podium, so you'll have to forgive me. I tend to move a lot. I want to start today in 1847. I promise it won't take too long, but I want to tell a quick story. In 1847, there was this Hungarian physician named Ignaz Semmelweis who was practicing at the time in Vienna. He was practicing at the first obstetric clinic in Vienna, where at the time the maternal mortality rate due to puerperal fever was about 20% on average. What was interesting is that at the second obstetric clinic, which was actually in the same physical location as the first obstetric clinic, the maternal mortality rate due to puerperal fever was actually only about 4% or less. And Semmelweis was one of the first people to kind of notice this and think that, hang on, there's something wrong. So being a scientist, he decided to sort of remove variables from the equation and look at what was different between these two facilities. And he quickly came to the realization that the main difference was that the first obstetric clinic was used for the instruction of medical students and is where doctors practiced. The second obstetric clinic was where midwives practiced their trade. Now, what's the fundamental difference there? The basic difference is that in the first obstetric clinic, medical students and doctors trained on cadavers. So they, used these dead bodies to do anatomy and other things. And so Semmelweis then proposed this theory that these medical students and doctors were carrying cadaverous particles from the cadavers to the live patients and transmitting this disease in some weird, unknown way. As a result, Semmelweis instituted the world's first policy of hand washing. And what happened next was kind of remarkable. I think in the month before he implemented this policy, the maternal mortality rate in the first clinic due to puerperal fever was about 18%. In the 3 months immediately following institution of that policy, the maternal mortality rate dropped to below 2%. And even and in that year, there were even 2 months that the mortality rate dropped to 0. Now, you would think that with an intervention of this nature, something as simple as that, where the effects were so clear, the data was so obvious, that this revolution of hand washing would have swept Europe and the rest of the world by storm. And you'd be wrong. And it turns out that there are a couple of big challenges. Number one, at the time, doctors were, and still today, are scientists and primarily gentlemen at that time. And how dare you accuse them of actually killing the people that they're there to treat? Secondly, this theory of cadaverous particles was just such a loose and kind of crazy idea that nobody could really get their heads around. It'd actually be another 20 years before Pasteur proved the germ theory of disease. Now, the story actually has a relatively tragic end. Semmelweis dedicated the rest of his life to trying to convince the medical profession that hand washing was a really good idea. Eventually ended up going crazy, was committed to a mental institution, and on commitment, actually realized what was happening, tried to escape, was beaten by the guards, and died 2 weeks later from infections sustained by the wounds that he got. So sort of an ironic, tragic ending. Now, the question is, why do I tell that story? I tell that story because clearly in 1847, in the next couple of decades, the status quo in this world was strong. So strong that it couldn't actually overcome this amazing data that had been generated by this simple intervention. And what really strikes me as interesting is that the status quo in many, many industries remains strong today, even in the face of data. Now, a quick question. How many folks here are federal government employees? Okay, a good number of you. So this will then sound somewhat familiar. Let me actually, how many of you are HHS employees? Some version of HHS. Okay. So HHS is not unlike many other government entities. It's a big agency. We have about 90,000 full-time employees, maybe 3 times that when it comes to contractors. We are very siloed, very risk-averse, very bureaucratic, very filled with red tape, sort of command and control oriented. And I have this set of slides that I like to show sometimes when I'm describing this. HHS is made up of 11 operating divisions, NIH being one of them, all of which are very independent. If you go into one of those operating divisions, say NIH, you've got 27 centers, or 27 institutes, each of which operates somewhat independently in a silo. If you blow up one of those, say the National Cancer Institute, you get another 28 divisions or offices or bureaus, and you can keep going on and on and on, which is an illustration of part of the challenge. We have a very, very strong status quo towards this bureaucratic system that we have here at HHS and across the federal government. And we think that in order to effectively respond to the challenges of the modern time, and with technology advancing, with new developments coming every second of every day, we need to be able to respond much more proactively in many cases and much more quickly in a reactive sense when we have to. So that's the challenge. In order to take up this challenge, we have created at HHS this thing we call the HHS Idea Lab. And the idea behind the Idea Lab is pretty simple. We want to essentially catalyze this thing called innovation, leveraging data to create a more modern and effective government, one that is risk aware as opposed to risk averse, one that is able to respond effectively to the challenges that are being thrown at us in the modern time. So we have, after a great deal of experimentation, kind of settled into a few major areas that we focus on when we try to explore and expand this area for the department. Number one, we are focusing on investing in our internal workforce. We have 90,000 employees at HHS, and one of the things that I've learned over the last several years in government is that the stereotype of the government bureaucrat, for the most part, is actually a false stereotype. We have some of the most amazing, intelligent, dedicated, there for the right reasons kind of people that you'll ever meet in your life. And the problem is they have all these great ideas, but they're tied by the bureaucracy, right? And they're tied by the history, they're tied by the culture, they're tied by the status quo. And so if there's something that we can do to invest in these people, to give them the space to operate, to let them explore their ideas and experiment without fear of failure, we actually believe that we can massively expand the footprint and the portfolio that HHS is able to operate effectively in. We do this through three mechanisms. Number one, we have a program called HHS Ignite, which is, think of it like a Silicon Valley accelerator. It's a 3-month program. We give teams the time. We give them up to $5,000. It turns out, by the way, that the money is the least important part of the whole thing. Many teams don't actually use a single dime. But more importantly, and the most important thing that we found, is that we give them methodological training in things that we typically don't train people in government. So this is human-centered design, design thinking, lean startup, business model canvas type stuff. And what happens is these teams go through a 3-day boot camp. They learn all of these different rapid iteration and experimentation techniques, and then go off and put them into practice and see what they can do in 3 months to generate data to validate whether or not their idea is good or works. At the end of that 3 months, they come back. We convene what we have affectionately called a shark tank of operating division heads and people who have the ability to kind of give a thumbs up and thumbs down, and those people then present their work and their results to this committee, who, and then what they want for next steps, who then say yes or no, let's go forward with this or let's not. The next piece of this universe is something called HHS Ventures. So think of it like a venture fund. It's a essentially risk capital for those ideas that have shown promise and have shown some valuable progress in terms of the data that they've been able to collect, but are still a little too risky for the standard funding mechanisms. The final piece is something called HHS Innovates, which I hope the folks in the room from HHS know about, since we've been doing this for about 4 years now. But it's basically an employee recognition program where we want to take people who have done interesting things, who have challenged the status quo in some way, successful or unsuccessful, and hold them up as examples of what we're looking for. Now, I want to tell a quick story about the most recent round of HHS Ignite, because I think it's somewhat relevant to what you guys are talking about today. One of my favorite projects in this most recent round, which ended about a month and a half ago, was these 2 women who work at the White River Service Unit, part of the Indian Health Service. So for those of you who don't know, one of the things HHS does is operate a health system. We have 120 hospitals in the Indian Health Service across the country. These are in tribal areas and reservations. And these 2 women who work at the White River Service Unit had this sort of realization, which is that the the average number of emergency room visits in Indian Health Service hospitals is about 3 times the national average. And the reason for that is actually relatively straightforward. It's cultural. People tend to go to the ER for just about everything in these places. Prescription refills, physicals, true emergent situations, you name it. And so that's a big problem because these increased number of ER visits leads to much longer wait times, which leads directly to people who leave without being seen. The percentages of people who leave without being seen at IHS hospitals is about 20 to 25% on average, a quarter of the people, whereas nationally it's about 2%. So there's a big, big problem there. So they had this idea that they wanted to test out. They said, what if we put an electronic kiosk in the emergency room and let people self-triage when they get there? So if they hit a button that says, I'm here for a prescription refill, they don't have to sit there and wait. They can just get the prescription refill and go. So they learned all of these techniques that we taught them as part of this boot camp. They went back to the White River Service Unit, and they started talking to their customers. And the first thing they recognized was that this solution wasn't actually going to work. Culturally, it just wasn't, this kiosk, this electronic system wasn't going to be accepted. This is a pretty rural area. Many of the IHS hospitals are in rural areas. The smartphone and technology penetration is relatively low. It's just not necessarily as common as it is today in other parts of the country. And so they said, okay, let's go old school. Let's create a paper form, very simple paper form with 4 checkboxes on it. We'll give it to the receptionist at the ER, and anytime somebody comes in, the receptionist will, ask a couple of questions, check a box, and send them in the right direction. Turns out that wouldn't work either because these are very, very small communities, and if people just felt uncomfortable basically giving their personal information to somebody who was not a trained medical professional. So they said, all right, we'll get a trained medical professional, we'll put them in the emergency room, we'll have them do the triage. And then it turns out that wouldn't work either because there's this law called EMTALA, which basically says if anybody walks through the door of an emergency room, they have to be fully triaged. So their 3 months are almost up here, right? They're scratching their heads. They're trying to figure out what to do. What I like so far is that they've pivoted 3 times. They've tried to figure out how to do this. Every time they've hit a roadblock, they've gone in a slightly different direction. But then they had a really interesting idea, which is that they looked across the private sector. And they said, in the private sector, people have tried this quote-unquote fast-track ER process, which basically envisions a redesign of the physical space of the emergency room to get people through a much quicker triage process. So they designed this new, they wanted to test this new fast-track process within the IHS clinic. So they said, all right, when people come in now, instead of waiting, what we're actually going to have them do is go through this quick triage, but a full triage, as the law dictates. If they are here for a non-emergent situation, we will direct them to these rooms that we've converted into quote-unquote fast-track rooms where they will be seen by a doctor. They will get whatever they need to have done, and they'll be able to go home instead of going and waiting. So they put this into practice. They tested it for 4 days in the emergency department at the White River Service Unit, and the results were actually pretty remarkable. In those 4 days, the percentage of patients that left without being seen dropped from about 18%, which is what they had measured just before, to about 1.25%. So a very simple intervention, right? They then said, okay, well, what else, so this is obviously great for public health, right? If people are now getting prescription refills and physicals and things like that, wonderful. They're actually going to be much better in terms of their health. But they also decided to do a revenue analysis, and they realized that if they invested $80,000 in rebuilding the ER to fit this new process, they could actually return conservatively $6 million of uncaptured or lost revenue to the White River Service Unit every year. Now, if you think about it, that's $6 million for one IHS hospital. Multiply that by 120 conservatively across the country, and that's some pretty real money, right, that can actually be directed specifically to patient care, which these places, and they need the money, right? They could use this money in a big way. So I love this story, right, because these are 2 people. They never had any formal training in this kind of iterative approach. They weren't familiar with lean startup or MVP, minimum viable product, or anything like that. But they took these ideas. They realized that by talking to their users, they could quickly identify what wasn't going to work, go slightly different directions until they found something that did. Not revolutionary by any stretch of the imagination, but the process was fascinating, and where they've gotten to has been really interesting. Now, we're trying to help them figure out how to operationalize this. It turns out that there are all kinds of weird laws around how money is appropriated to the IHS system and what can be used for construction and what can't, but that's part of our job, is to figure out how these things can actually be made better. So that's the first bucket. I know I'm probably running short on time, so I'll kind of try to condense here. The second area that we focus on is the fact that while we have these 90,000 amazing employees, we also know that we don't know everything. And there are lots of skills and experiences and techniques on the outside of HHS and the outside of the federal government that we need to bring in to solve some complex problems. So we've created two what we call in-residence programs, where we bring people in from the outside world on a time-limited basis to solve some of the issues. The first one is HHS Entrepreneurs, where we solicit problems from the operating divisions from specific areas that have kind of complex problems that need to be solved, and we bring people in for no more than 12 months to solve those problems. The 12-month thing is important because it turns out that if you only have 12 months to do something, you by definition have to do things differently than the government tends to do things. And so not only are we sort of challenging the status quo in terms of what's possible and what's not, we're also embedding those skills within the federal workforce, which is useful much longer past when these people actually end up leaving. The second one is something called the Innovator in Residence program, and this is it's interesting. It's a little different. We partner with a nonprofit external to HHS that has a similar topical interest to the department in some way, shape, or form. The topic is usually broad and cross-cutting. It involves multiple HHS operating divisions and below, and we recruit somebody basically for a period of 2 years to come in and explore that topic. We very specifically do not make the problem specific. We leave it very vague because we want to bring people in with ideas and let them kind of go crazy, right? Give them the imprimatur of HHS. Let them use the name of the government to do the convening and have the conversations that they need to have, but then use their experiences to kind of generate great ideas. So I want to talk briefly about one of these folks that we have today. His name's Nag Murthy, and he's sponsored by the West Health Institute. His topic is patient engagement, and he's taken it in some really interesting directions, but one in particular that's very relevant for today. He's developed, or is working right now on something he calls Project Boundary. Now, Project Boundary is a pretty simple idea. Basically, his question is, can we use cues that we place into the built environment to actually get people to try to do different things, to try to change their behaviors? So we're doing this through technology. How many of you have heard of iBeacons? Probably a bunch of you. Okay, so there are these little tiny, some are this big, some are slightly bigger, low-power Bluetooth emitting devices that you basically stick on walls or stick wherever. And the Bluetooth readers in smartphones, or the Bluetooth chips in smartphones, can tell basically proximity to these sensors and triangulate positions based on where you have the beacons located and all kinds of stuff like that. Now, that's not necessarily interesting in and of itself, but what is interesting is that you can write an application on the phone to actually do interesting things with that data. So, for example, one of the things that we're testing is if I walk up to an elevator bank in the Humphrey building and I have this app on my phone, and the app buzzes at me and says, hey, we notice you're about to take the elevator, maybe you should take the stairs. And then we put beacons in the stairwell so we can tell when people are actually climbing the stairs after that message, and maybe gamify the experience a little bit, create a leaderboard, try to get people to play the game in that way. Does that actually change people's behaviors? So it was actually an interesting process creating this, what we call a beacosphere. The facilities people at HHS and security people didn't quite get it at first. It was it took a little convincing. But we've got the beacons in place throughout a bunch of the building, and we had a beta version of the app that we tested for a little while, and we're now taking some learnings from that and embedding it into a future version that we'll release relatively soon as part of NOG's experimentation around this patient engagement type stuff. If you think about it, you can do all kinds of stuff, right? Imagine placing a beacon in the cafeteria in the Humphrey building where all the chips are, right? And you're standing in front of it trying to decide what bag of Fritos you want to get, but instead it suggests maybe you should have an apple, right? So you can imagine maybe leveraging some of this location information in a specific environment to get people to do different things. So that's one of the things NOG's working on. It's pretty interesting. Some of the data that's been coming back initially from that is pretty fascinating. And I should say also that none of this stuff is proprietary, right? We're the government, so we want to make all of this public as we do it. So I think what I'm hoping is that the information we collect will be useful to folks like you guys when you're thinking about this kind of stuff. The third and final piece is one that really involves breaking down the silos that exist across the department and essentially catalyzing communities of people from all of the different operating divisions at many different levels to try to help us solve some big cross-cutting issues. And perhaps the prototypical example of this is the Health Data Initiative that Chris was talking about. So I just want to say a few words about that because it is pretty important. Health Data Initiative started about 4 or 5 years ago, literally in a room in the Institute of Medicine with about 45 people and 30 data sets on a table. And we didn't know. We thought the data would be useful. We thought it might be valuable for people to access in machine-readable ways, but we weren't sure. And so we said to everybody after the course of this half-day meeting, look, here are 30 data sets. Here's a challenge. Go away for 30 days. Come back 30 days later and let us know if you've built anything interesting with these things. We had no idea what was going to happen. 30 days later, these 45 people came back together and lo and behold had created 24 brand new applications using this data. Now some were good, some were not so good, but it kind of didn't matter. What it proved was that this stuff was valuable and there was something there. So that actually became sort of post facto the first Health Data Palooza. That was the 45 people in a room. And as Chris mentioned today, we just did the 5th one in June. We had over 2,000 people at the Marriott in Woodley Park. And if you think about the growth of that just in a few years, it's pretty remarkable, right? This is something that nobody really thought too much about except for academics and researchers. And now you've got, I mean, this room was filled with venture capitalists and entrepreneurs and developers and people that you would never have expected to be interested in this idea of health data. We've seen data in the health and human services ecosystem fundamentally start to transform many different areas. Quantified self and personal data is one area. Clinical decision support is another area. Looking at, if you guys probably saw all the data that CMS released last year and this year around physician payments by drug companies and outpatient costs and inpatient costs. All of these things have been used to analyze the healthcare ecosystem in really interesting ways. Ways that have actually started to change the way that we do things within HHS and the outside world. And so to me, it's this data catalyst is pretty fascinating to me. And it's fascinating how just by injecting the ecosystem with a little bit of information and opening up the doors a little bit, we can actually start to fundamentally change things. So I'll close just very briefly. The interesting thing to me is that over the course of the last few years, we've engaged within these general Idea Lab activities, I would say, just over 1,000 people or so within HHS, so a little more than 1% of the HHS population. Now, that doesn't sound like a lot, but as you guys know, it's a big kind of, as I said, very hierarchical organization, so it takes a while. But what's interesting to me is that we're really starting to hear a change, right? We're starting, this data, for example. 4 years ago, nobody ever would have thought that releasing data was a good idea, or at least, without a lot of discussion and many lawyers weighing in and all kinds of things like that. Now, when anybody's developing a new system that's going to be collecting data, or they have a data set that they've been using for years, the first thing they think is, for the most part, is, how do we put this out there? How do we put this out there in a machine-readable format so people can use it? And we get a lot of calls every day from folks within HHS, and actually now outside of HHS. For example, state departments of health have called us quite a bit recently because they want to join in this process. California just recently launched, California's Department of Health just recently launched an open data portal, and we had a hand in kind of helping to convince some of the people that were a little recalcitrant in Sacramento that this was a good idea, and we federated all those data sets into healthdata.gov. So stuff's changing, right? I mean, all of these things are having an impact. I think the more we continue to push this, the broader the impact will be. And I look forward to seeing where it goes. So I just want to close by saying everything I talked about today, you can find details on our website about it. It's hhs.gov/idealab. And keep an eye out for various programs that we put up because we like to solicit ideas from inside of HHS. We also, as I said, recruit from external sources. So we're always looking for new people to join the fun and to help us on this journey. So thank you guys very much. I really appreciate the time, and I think we're going to have some time for Q&A.
So
great.
Why don't you stay right there?
I will. I love this standing O thing. This is great. Thank you.
All right, so we have a few minutes for Q&A, and so in the interest of you hearing Bryan's remarks more than my questions, what I might do is, if it works, I'll just stand up here, and I have some prefab Q&A, and then we can go for the real fab Q&A. So Bryan, I wanted to thank you for that, and I wanted to follow up with a question. So there's one thing in your remarks that caught me. That was an analogy to it. So a lot of the folks in this room, you were talking about an organization that is relatively slow to change, risk averse, opaque with regard to information flow. I think you were talking about HHS, but you could have been talking about the architecture, engineering, and construction professions. That actually is a fairly good description. So when you think back to the origins of, and I was kind of thinking about what you laid out, you talked about the role of leadership, the role of innovation, and the role of data as the pillars. And do you think there's some lessons that we can take in terms of, a lot of us in the building sector there's a lot of risk aversion around that flow of data.
Right.
And as an industry, we're a massive industry that is scared to take the first step. Is there anything from your experience that you might elaborate on a little bit in terms of how we can make that first step?
So that's interesting. It's funny. My mindset is government right now, right? So I always just kind of focus on the government stuff, but almost every time I talk about this, somebody comes up to me and says, yeah, in my industry, it's kind of the same way, right? So it doesn't surprise me. I don't know too much about the construction and building industry, so I can't tell you from personal experience, but I trust you on this. I think, for me, what I've seen over the past, and actually in all of the different jobs in government, whether it's local, state, or federal, the same thing has held true, which is that when you're trying to change something sort of big and important, like culture and like the way people think about things, you're always going to have an adoption curve that's shaped like a bell, right? You're going to have people that are on the far left side of the curve who literally are never going to change, right? I mean, you will not win with those people. All the way through to the same small number of people who are ready and willing and able to make a difference at that exact moment in time. And so what we've really done is focus on those early adopters, right? Find the people who desperately want to do something different and just need the ability to do so, just need the air cover. Maybe they just need a little bit of resource. Maybe they just need a little bit of training. Or maybe they just need somebody to push them, right? And help them be successful, right? Or help them learn quickly what doesn't work, but then hold them up as sort of paradigms of what you're trying to do. And we found that if we can engage the people that are on that end of the spectrum, what happens relatively quickly is you start to filter down to this side of the curve, right? The people who are just below the early adopters say, wait a minute, I can do this stuff too, and I want to be a part of it. Now, it's not fast, right? None of this stuff is going to happen literally like that. It takes time, and it takes effort, and it takes really being, I think, having the ability to aggregate risk for people and things like that. I mean, I've literally written emails to people within HHS that say things like, Dear John, I order you to do X, Y, and Z, sincerely, Bryan. Just in case something goes wrong, they can pull out the email and say, he told me to do it. But that's part of it, right? And the neat thing is that, because I work in the Secretary's office, I have the ability to kind of aggregate some of that risk up through sort of my office and say, look, this is something that we're interested in doing. If it doesn't work, that's okay. We've got your back. And so that's really where I would start. I mean, it's got to start at one little piece, right?
That's great. And some of you guys know that this stuff is there. So just a little bit one quick comment on it, because it's not an awesome description of green building. That's actually what green building is supposed to do. Gradual change, pulling the curve to the left, all that stuff, right? And then you have your early adopters in this room. I mean, I'm looking at you, Ken. A guy who's been mapping individual rooms in HHS in NIH for a decade. Question.
Yes, thank you. First of all, thank you very much for the presentation. It's a nice kickoff for the day. Paul Geist from the NIH, D. Poughkeepsie. So great thinking, good programs, good initiatives. I want to ask you a question in particular about HHS Ignite and the example that you used, and use that as an example to ask you about root issues and root causes.
Sure.
So it was very interesting to hear about the process and the thinking and how it went on. But at the same time, at what juncture do you sit down, whether it's early, middle, or late, about if it's $80,000 for one IHS emergency room or $80,000 for 120, which also begins to be significant money, where what you described sounded like expanding an emergency room to also be a general services clinic at the same time, because you said in the beginning, the culture is that you go to an emergency room for all your medical services.
Right.
So the whole logic train was keeping that root behavior intact.
Right.
Where does the discussion come in that is this the right thing to do, to have everyone continue to come to the emergency room culturally or not? Because you also invoked how do we change cultures into the equation.
So it's a great question. In that particular example, the thought is basically the quickest way to change the culture is to educate people at the moment of service provision. And so the idea is if we can invest in changing the ecosystem and have a positive ROI in terms of financial returns, so we're offsetting the money anyway. What we can do at that point is as people go through this fast-track process, and do things like get prescription refills or the standard physical appointment that they need or what have you, they can be educated at that moment in time that the emergency department is not necessarily the appropriate place for that. And by the way, the next time you need a prescription refill, just call this phone number, right? Or just go to this doctor as opposed to coming into the ER. And so the idea is over time, by educating people at the point of service, we can actually change behaviors for the long term.
Even though structurally you're reinforcing behavior.
Yeah, it's there's been a lot of effort over the past decade to try to change this behavior in these cultures, and it hasn't changed, right? And so if we can make a minor investment that does have a positive return, and I want to emphasize that, right? Because it's not just throwing money away, right? There is this revenue that will be generated by the investment. If we can make that investment, show people the value of actually doing something different, right? Then hopefully we can change behavior. But at the end of the day, if at the same time we change the physical layout of the emergency department and enable them to process people in a faster, more accurate way, maybe you don't need to change behavior for those populations, right? So that'll be part of the experiment.
My question was, where in that process were these things talked about?
They were talked about throughout the whole thing, actually. And so the team itself was focused on solving or experimenting with solutions to the one problem of people essentially leaving without being seen, right? But during the course of the 3 months, that was one of the things that came up in conversation quite specifically.
So we're going to grab one more question, of course, from Whitney.
Hi, so Whitney Austin Gray from Canon Design. We spoke last week. Thank you so much for being here, Bryan. Because it's really early in the morning, I just want to ask a huge question. Why not throw it out? So a lot of people in this room are challenged with the idea that we design and hope to design healthy places. It's very hard for us to always measure, right, the performance of those places, and to demonstrate the investment is worthwhile. Right. And we have this huge opportunity of opening up data and having it more available, that we're able to track movement, we're able to track outcomes. So you talked about quantified self, maybe there's a quantified community. We create buildings for communities, we create places for communities. So I just wanted to throw out kind of a fun question in some ways of years from now, as you're kind of looking to the future and how to work with this industry and thinking about place and data and that transparency and understanding better about how humans are using space. What ideas come to mind for you?
That's a good question. So one of the things that really interests me is the proliferation of sensors, right? I mean, there's sensors in everything that we carry today, and they're embedded in many, many different places that are sort of new but expanding rapidly. Not only that, but these sensors are all going to be connected, right? The whole Internet of Things thing. And so we're actually, if you think about the beacosphere that we've built at HHS, that's sort of one very early simple example of how you can take sensors, distribute them throughout an environment, integrate them with devices that people happen to be carrying, and generate a bunch of information from that, and then use that information to hopefully help encourage people to do different things. It's really tip of the iceberg kind of stuff, right? Because these beacons are, it's relatively difficult actually to really get the signals, understand the signals that are coming from them in the devices and try to triangulate positions. You can get close but not quite exact. And so the point is that as the future goes on, I think a lot of the potential lies in the fact that the sensor technology, the connectivity, everything else is going to be getting a lot better, and we'll be able to leverage that to actually start to do much more interesting things. I am a big fan, obviously, of publishing data. Now, in this particular case, it's got to be somewhat aggregated and anonymized, because you don't necessarily want to say that, hey, Bryan Sivak is not, hey, you're not taking the stairs, man, like, come on. But you can generalize it, right, by demographics, by gender, by all kinds of stuff, and actually start to then have targeted interventions when you need to, in order to get people to change behaviors. And I think that's really where this smart building thing kind of comes into play, right? Embedding the intelligence within the structures themselves, and then leveraging all of the other technology that people have and that they connect. Now, that's just my sort of thing. I'm sure that you guys who are all experts in this have many, many, many other really interesting ideas, and I'm actually super curious to know what they are. But it's a great question, and I'm interested to see where it goes.
It's actually a perfect place to stop. So thank you. So thank you very much.
Thank you very much. Thank you, guys. Appreciate it.
So there's apparently a musical interlude. Oh. One second.
Yeah, go ahead. Okay, stay standing if you would. Okay? Go ahead.
Okay. Angela's got a plan.